Good afternoon, and thanks for tuning in to the American Ambulance Association's Medicare Ground Ambulance Data Collection System webinar. This webinar is being recorded. The recording link and slide deck will be published in tomorrow's Daily Digest that is automatically emailed to all AAA members. To ask questions, please use the Q&A function in Zoom, which is represented by the double dialog bubble button. The chat function will be disabled for participants, but will be used by staff to share important information. Thank you again, and with that, it's my pleasure to introduce today's presenter, Andrew Mulcahy. Andrew is a senior health policy researcher at RAND, a nonprofit research organization helping CMS develop and implement the ground ambulance data collection system. Andrew, welcome.
Thanks very much. It's a pleasure to be here. I have a presentation today that will cover the background, the foundation for GADCS, the Ground Ambulance Data Collection System, and then quickly walk through each of the sections. As we go today, I'll point out some tips and frequently asked questions, some recent changes, to try to highlight some aspects of GADCS and data collection that you might want to start thinking about sooner rather than later. There's been some timeline changes along the way with this new data collection effort due to the COVID-19 public health emergency, but it is now really right around the corner. For many organizations, data collection will start in just a couple weeks, January 1. For others, it may start a little later. But if you're in that first cohort, and I'll talk more about the timing in a minute, if you're in that first cohort, it really is go time to make sure that the information you have in your systems that you're planning to collect is set up now, so that when January 1 rolls around, you have that information collected, so that when it ultimately is time in a year down the road to report, you'll have everything on hand. So I hope today's session will provide that broad overview. We'll save about 10 minutes at the end for Q&A. If you do have any questions, please do drop them into that Q&A box. I'll check periodically, glance over and see if there's anything I can answer as I go through the slides today. I just should mention this is from the RAND Corporation, which is working on a contract with CMS to help design in prior years and now implement the ground ambulance data collection system. The comments today are my own. You may also have participated in some of the CMS sponsored presentations that run most Thursdays. I'll turn back on the very last slide to point to where you can find all of those previously recorded webinars. There's a whole series of them that may also be of interest. So moving on to a quick agenda, we'll do this overview of the system first, describe the specific information in just a slide per section, describe the specific information you'll need to collect and ultimately report. And then in the last couple slides, I'll point you to some other helpful resources that will help you prep. So moving into this overview of the GADCS, just as a quick background, you get a lot of questions, why is CMS doing this? And the answer is they were required by Congress to do it. Now, by statute, they need to collect information on cost, revenue, utilization, and other information from a representative sample of ground ambulance organizations. We'll use that term ground ambulance organizations today. It really is in Medicare parlance, a mix of suppliers. Most ground ambulance organizations are Medicare suppliers. There are some that are providers of service, which are hospitals and SNFs and other kinds of provider-based organizations. So we'll use that term organizations to refer collectively to the set of providers and suppliers that bill Medicare for ground ambulance services. Another common question is participation required? The answer there is yes. There's a 10% payment reduction that CMS may levy against AFS, ambulance fee schedule services, for organizations that don't sufficiently submit information. And I think it's important to highlight why this is happening, why Congress went down this road, why this data collection is very important, why it's important to make sure the data you collect and report is accurate. The data after it comes in will be used by CMS, but also sent to MedPAC, which is the Medicare Payment Advisory Commission. They're a group that's separate from CMS that advises Congress and CMS on policy issues. Here, there's specific charge, just like CMS was required to collect this information, MedPAC's required to analyze the information and write a report. The focus of that report is on the adequacy of Medicare's payment rates, given the actual expenses and situation on the ground for ground ambulance organizations. So, this is a case where the data that you'll work hard to collect and report will have this direct link into what MedPAC sees, and then likely changes in policy and payment rates down the road. So this is will shine a light on the operations of ground and the finances of ground ambulance organizations in a way that simply there hasn't been good information on before. It's a real opportunity for MedPAC to dig into it and give Congress and CMS some advice on Medicare payment rates. So a couple other terms I'll use over and over again today. I'll keep on saying the word instrument, and it's because I can't help myself. Instrument is the word we use to refer to the set of questions. So if you think about GADCS in many ways as an online web-based survey, the instrument is the set of questions that you'll be asked. There's a printable version of those questions of the instrument up on the Ambulances Services Center website. Put the URL here. If you Google Medicare ground ambulance, I think it's the first thing that comes up. So there is this printable version that has 40 some odd pages and looks pretty daunting. The good news is no one will ever have to fill out that PDF version. The PDF version is a great reference and it does list all the questions there. Ultimately, though, CMS is right now developing a web-based version of that instrument. So sometimes we refer to the system as a broader notion that includes the questions, the instrument, but also includes other features, like how you'll get a username and log in, and then how you'll access this much cleaner, more streamlined web-based version of the questions, rather than have to flip back and forth on a 40 some odd page PDF. You'll see as we go through today, the specific questions that you'll get in some of the early sections, like section 2 of the instrument, do ask about your organization's characteristics. And one really nice feature of the web-based instrument is that it tailors the questions you get later on based on your answers in those early questions. So it's a great way to trim down the number of questions you have to read and respond to. It's a great way to accommodate all of the heterogeneity, all of the different characteristics of ground ambulance organizations that CMS knows are out in the industry. Very different looking organizations. And that web-based version will tailor your experience and the specific questions you'll have to answer to match up with your characteristics, rather than reading through a bunch of questions in the PDF that may not apply to you. So I'd encourage everyone to take a look at that printable version of the instrument. It's a great place to take a pencil and jot down some answers, maybe highlight questions you can easily answer given the data you have at your fingertips, and highlight other questions, maybe in a red or pink or something a little more obnoxious, where you might need to pay a little more attention in the next 12 months as you collect data, where you don't right now collect certain kinds of information. Well worth a read through, but just keep in mind, you'll never actually be filling that paper version in and sending it in. A couple other key concepts on timing. So there's this 12-month data collection period that each ground ambulance organization will have. That starts at a different time for different organizations. You have your choice of using a calendar year basis for that data collection period, or if your organization uses a fiscal year that's different, you can use another period like your organization's fiscal year. Say if it starts mid-year, that's also fine. So you have some flexibility in when that data collection period starts. When it does start, though, that starts a 12-month clock. You have 12 months over which you'll collect data. There's no reporting through that 12 months. You wait till you get to the end of the 12 months. And then that starts the second period called the data reporting period. And that's a 5-month period. So After you collect data for 12 months, then you have 5 months to actually submit the information to CMS. I have an example here. I'll also run through an example on a slide or two that visually that might be a little clearer. A lot of questions about who's required to report and does my organization have to report? A couple notes on what's already happened, and the timing here did deviate from CMS's original plan because of the public health emergency and emergency waivers that CMS granted along the way. There were some changes in who's going to report, collect, and then report at different times. So CMS has already selected roughly half of ground ambulance organizations, something like 10,000 plus organizations in the country. So that means there are roughly 5,000 plus that are already selected to collect and report data. So they're split up into these groups called years. So about a quarter of organizations, or roughly 2,500, are in year one, another roughly 2,500 are in year two. And then the remaining half of organizations haven't been selected yet as part of year one or year two, but they very likely will be selected in year three and year four coming up. If you're not sure whether your organization is or isn't part of year one or year two, I'd encourage you to go to the link here at the bottom of this slide, or Google for CMS ground ambulance again, and check out the Excel lists of NPIs that are required to collect and report as part of year one or year two. We'll post it up there. You can sort by primary practice state. You can also look at name, or of course MPI. The sampling is by MPI. So if you operate an MPI that's on that list, you bill under an MPI on that list, then you are responsible for collecting information starting as soon as January 1 of next year. So this gives you a sense for the timeline here. And again, there's another place where there have been some shifts. For the organizations that find themselves on those two posted lists, those were selected in late 2019 and in mid to late 2020. All of those organizations, that's roughly 5,000 organizations, will collect data at some point starting in 2022. I mentioned you have your choice of starting over the calendar year or your organization's fiscal year. We think many organizations will report over a calendar year. So that means that your data collection period would run January 1st, 2022 through the end of, through December 31st of 2022. So that these are these orange bars. You'll notice that for year one and year two, things overlap because of the way that the changes in timelines due to the public health emergency worked out. Year one and year two will now go together. And then after the end of that 12-month period, you'll report over a 5-month period. The orange and gray bars look the way they do on this slide because this illustrates what would happen for an organization that's reporting with that January 1 start date over a calendar year. If your fiscal year starts July 1, then this entire timeline with the orange and gray bars would shift out to the right by 6 months. And your data collection period would start July 1, end mid-2023, and then you'd have 5 months after that to report to you. The other important point on this slide is that year 3 and year 4 organizations will be sampled sometime next year, and then they'll collect data starting in 2023 and then report data starting in 2024. So just like for the year 1 and 2 going together, year 3 and 4 will go together, the other half of the industry roughly will go together and pushed out by 1 year. Quick note on the notification process. CMS will send notification letters to all of the year 1 and year 2 selected organizations starting this month. Those organizations that are selected, when you get the letter, you have 30 days to send some relatively limited amount of information to CMS right away. One of them is acknowledging receipt. Another thing you have to do is to submit the contact info for someone so that CMS knows who to get in touch with about this. And then the third piece, and most importantly, is you have to submit the start date for your 12-month data collection period. So this is where you tell CMS right off the bat, are we going to go over the calendar year or our fiscal year? And then if it is a fiscal year, when would it start? And that will feed into the rest of CMS's systems and determine when you'll need to report, and also pre-populate a bunch of dates in the web-based data collection instrument. This is just kind of a summary again to put everything on one slide as a recap. Before you do anything, this is like a today kind of note for a lot of organizations. To prep for this, you can listen to sessions like this. You can go back and listen through the library of educational webinars and review the materials up on the CMS website. I think most importantly, you can print out that web-based version of the instrument, flip through and see where there might be holes in the data you collect and have readily available now. And then right after you get that letter, tell CMS when your data collection period starts. So those are the immediate steps for year 1 and year 2 organizations. The next middle period is this 12-month span where you'll be collecting data. You don't have to actively do anything in terms of submit anything to CMS during this time, but you do need to be paying attention to what's going on in terms of on your accounting side, basically in terms of staff hours worked, things like that, as we'll talk about a little bit in a slide or two. That's 12 months. And then at the end of that 12-month period, there's this 5-month span where you'll need to get access to the web-based GADCS and then actually report your information to CMS before that 5-month period is up. All right, that was kind of the overview and some nuts and bolts. We'll get now into an overview of the instrument. There's a lot of detail in the instrument that I'll skip over today. From our experience talking through the instrument with ground ambulance organizations, much of the information that you'll be asked to report is information you probably already collect. There may be a couple places where that's not the case. That's where I suggest focusing today as we go through this presentation. And then again, if you look through that PDF, great exercises to circle the areas where you might be missing something. Much of this, though, is information that we know many organizations already track. I've boiled this down to one slide per section. There are a couple of general rules, tips, rules of thumb I'll run through just on this first slide before we get in. I think one question we often get is, well, this is a Medicare effort, so do we just report on what's going on for services we provide to Medicare beneficiaries? And the answer there is no. You're reporting on your expenses, revenue, services across your entire operation. And in many ways that simplifies things for organizations as they report. Otherwise, you'd have to go through and do some kind of accounting for what portion of your operation is specific to Medicare patients, which is sometimes hard to know, especially with the complicated split between fee-for-service Medicare and Medicare Advantage. The instructions throughout the instrument specify to think about your entire ground ambulance operation. There's some questions at the very end around revenue that ask you for revenue by payer. And there you can report your Medicare fee-for-service revenue as a separate number. But otherwise, you're reporting on your services, the volume and mix of services, expenses, and revenue across your entire ground ambulance operation. The questions are structured in such a way that map the information that organizations will sometimes track for accounting purposes, and many of the usual kind of best practices in accounting apply here too. You want to make sure that as you're thinking about your expenses and revenue, that things are reported only once. One of the challenges in the instrument is that the questions need to apply to all kinds of ground ambulance organizations. Some very large for-profit ground ambulance companies out there operating in many, many states under many MPIs. You have some big hospital-based delivery systems that bill Medicare separately for ground ambulance services. And then you have very small, rural, volunteer-based organizations. It really runs the gamut, as folks on the call know. And so there's some flexibility in the instructions on where to report and how to report certain things. the ask that we'd make of everyone collecting and reporting information is that you double check to make sure that everything's reported just once. Some some infamous categories of expenses that, because of the flexibility, can sometimes be hard to know where to put. Expenses related to medical directors is one example, where sometimes that goes in section 7 for labor, sometimes that's a contracted service and might go into section 11. The most important thing is that you report it just once. Where you put it, as long as you're following instructions, in some cases leaves a little leeway for your interpretation. So just as you're reviewing the information, think about that principle of reporting things only once. Another thing I've already touched on, you're collecting information over the entire 12-month data collection period. There are some organizations that ask whether this is something like monthly reporting or whether or not they'll have to upload monthly financial information. That's not the case. It's just a single reporting covering the entire 12-month data collection period that you'll do during that reporting period. There are a couple places in the instrument where the instructions specify you can take a guess. There's some areas where CMS understands it's hard to collect information. Even with a really concerted effort, it might be difficult to collect certain information. And so there are some places where a best guess or an estimate specifically asked for or allowed. That's fine. In other cases, in order to submit sufficient response, you do have to report, and CMS expects to get actual numbers reflecting your actual expenses, services, revenue, etc. And then many questions about what's in scope and out of scope. We'll cover a little bit of that today. I'll also point you to the frequently asked questions document up on the Ambulance Services website that has some great examples of how to think through certain scenarios. One very common one is a fire department-based ground ambulance organization, and where to think about drawing a line between, well, what expense is related to my ground ambulance operation versus fire. For cultural reasons, operational reasons, historical reasons, some organizations have an easier or relatively harder time doing that kind of allocation. And there's some guidelines some tips and guidelines that we've given in other webinars hosted by CMS that might be helpful. And again, the FAQ does have some examples. Also, some important distinctions about what's in scope and out of scope for organizations that are owned and operated by municipal governments. Those kinds of organizations often have certain expenses paid by, say, a city or town government, and there are some good guidelines in the FAQ about how to handle those cases. So with that, I'll move on to slide 13. This separates out the 13 sections of the instrument into a couple different categories. The first 4 ask about the characteristics of your organization. Most organizations will be able to click through these questions pretty quickly. Section 2, for example, asks questions about what kinds of broad services you provide, what's your ownership type, and a few questions on contact information. Those blue sections are asked first because they determine what questions you see in later sections. Section 5 and 6 asks about the volume and mixed services that you provide, the number of transports, for instance. The purple hues here in sections 7 through 12 ask about expenses in a bunch of different categories: labor, facilities, vehicles, all of which we heard from ground ambulance organizations are important to contributors to your total expenses and cost of operating. So they are organized by type, and we'll go through each of those in one slide today. And then the final section, section 13, asks about revenue. And this is a shorter section, does ask specifically for revenue from Medicare and other health insurers, health systems, and then revenue from all other sources. There are some checks and balances you can think about in this, the broader GADCS in this instrument. When you get through at the end of putting all your information in, for sections 7 through 12, the numbers you put in should tally up to what you think of as your total expenses at the end of the day for accounting purposes. And ditto for section 13 in revenue. There are actually some questions in section 12 and 13 asking just broad brush for your organization's total costs and revenue. And that's a good way to think about, did I capture everything that I should have included in reporting? If the numbers are way off, too high or too low, that's a sign that something might be up and you might need to go back and double check some things. So as I mentioned, section 2 focuses on organizational characteristics. And these are a lot of screening questions that determine what you see next. There are questions for whether your organization bills Medicare, other multiple national provider identifiers or NPIs. Questions about your ownership type, are you for-profit, nonprofit, government? Some really important questions about whether you're fire department based, police, or other public safety department based. Those questions trigger a pretty significant shift in the questions and the instructions you'll see later on. Because for organizations that are fire department based, say there is this need to tease out a share of your staffing, expenses, revenue that's related to ground ambulance. Questions on volunteer labor that maybe obviously determines whether later on in section 7, you're asked questions about volunteers, and some other questions about staffing models, whether you provide paramedic intercepts, some other screening questions that have implications later on. Section 3 is service area, and there are some questions that CMS has recently addressed and clarified about the definitions in this section. The way that you'll report your service area is using zip codes. And in the web-based version of the instrument, there are a couple methods to enter those zip codes that are under development. For some organizations, this will be as simple as typing in a zip code. If you serve out in California, say, serve a whole county, you might have a lot of zip codes. And so there are ways to select all the zip codes in a county, say, with just a couple clicks rather than typing them all in. You can also copy and paste in a list of zip codes. So many different ways to get the zip codes in. CMS fields a lot of questions about, well, what are these 2 service areas that section 3 asks you about? One is your primary service area, and one is your secondary service area. And the way this is teed up in terms of the instructions and the examples and definitions in section 3, CMS heard that from many organizations, they think of themselves as being the primary EMS organization, say, for some area, municipal government, county, town, jurisdiction, some area where your organization may have primary responsibility and where most of your services are probably furnished. There are these outlying areas, though, that some organizations serve only occasionally. For some EMS-based organizations, those are maybe surrounding jurisdictions where you provide services through mutual or auto aid arrangements. And then there's this third category where, once in a blue moon, you might have a pickup in some other area. So I'd encourage you to think about the definitions in the instrument for these 2 areas, the primary and secondary service area, and really use your best judgment on whether your organization, first of all, has a secondary service area at all. Not every organization does, and there's no requirement to have one. But if you think that applies to your organization, then say you do have one. And then also use your best judgment for reporting which zip codes go in your primary versus secondary service area. You can, as a rule, leave out those once in a blue moon type areas. Otherwise, the list of zip codes for some organizations would be quite extensive. So make take your best guess here. This is one place where your own perspective, it's okay to lean on your own perspective on how you think about your service area. There's no right or wrong answer here. And if you feel like the secondary service area concept doesn't apply to you, that's fine. Just say you don't have one and you won't be asked to enter zip codes for a secondary service area. Section 4 is about response times. This is only relevant to EMS organizations. another of many places in the instrument where you have some flexibility. There's a pre-programmed definition of a way to calculate response times. If your organization uses that, fantastic, you can use it. If not, you have the ability to write in basically your own definition. There are a couple other alternatives that will be pre-programmed in for you to select. And then there is a write-in field if you'd rather report something else. I will say there's one change. I should have highlighted this earlier. When I mentioned that CMS recently made some clarifications, that happened as part of the calendar year 2022 physician fee schedule final rule. CMS made a set of changes and clarifications through the final rule. Clarifying the definitions of primary and secondary service area was one of those changes. This is another one where in prior versions of the instrument, there was a question asking organizations to report their 90th percentile response time. The notion there is CMS is curious about, well, what are the real outlier response times? We know that many organizations shoot for a target here, and that often for the majority of responses meet that target. There are some, though, that for various reasons are maybe much longer. And so there was an original question asking for this 90th percentile response time that was difficult for many organizations to track and report. And one of the changes in Section 4 is to now ask for the average response time and also the share of responses where the response time is greater than twice that average, which might be a little easier for folks to track and report. This maybe is one of those kinds of information, one of the questions where you might not have this right at your fingertips. And so thinking about how you might track that now so that you come into the start of your data collection period in 2022 ready to record when that happens. It might be a great way to prep for GADCS for organizations that don't have that at their fingertips right now. Moving on to Section 5. Section 5 has a long list of definitions at the beginning, and the goal is to get a sense for the volume of services you provide of different types. One of the interesting features of Medicare's payment for ground ambulance services is that payments only made typically when there's actually a transport. So there are questions that ask about the number of transports, paid and unpaid, over your 12-month data collection period. But there are also questions that try to get at other kinds of activity, like your total number of ground ambulance responses. For some organizations, the number of responses will be considerably larger than the number of transports. You may have refusals, you may not be able to find patients, there may be multiple organizations responding to a call, and someone else transports a patient. So CMS thinks it's important to get that broader picture, and there are questions that get more broadly beyond just transports that where you'll be asked to collect and report information. One other clarification in the final rule was on the timing for paid transports. There's some timing challenges here where services are sometimes provided, billed, and then not paid for months, weeks, months, years, sometimes many months or years after service is furnished, payment might actually come in. And so the anchor for thinking about paid transports are the transports that your organization furnished during the data collection period that were paid in full or in part by the time you report data. CMS knows that that number will increase over time. And then if you came back a year later to ask, well, what share of those calendar year 2022 transports were paid, the number would obviously go up over time. And to standardize the way that data is being collected across all organizations, this is a clarification that CMS made in calendar year 2022 final rule. Section 6 asks about the types of services provided. This is a section where there are a couple broad categories like emergency versus non-emergency responses and services in your primary service area versus secondary service area if you report having a secondary service area. There's also a breakdown by HCPCS code, by CPT code. That's actually HCPCS code, but by type of service. And this is a section where we've heard many organizations will reach out to billing group, either in their organization, in sometimes a broader hospital setup, sometimes a company that you might contract out billing services. Those organizations, those groups that do billing, focus on billing, often run reports of different types. And we've heard that some organizations will have to reach out to those folks and ask for breakdowns by HCPCS code. Say, if you don't already get that from the folks who handle your billing, that's another great example of something you can ask about now ahead of the start of your data collection period. So it doesn't surprise folks when you get closer to that data reporting period deadline. This slide talks about sections 7 through 12 in a kind of holistic sense. So sections 7 through 11 ask about expenses in different categories, and those add up to the overall cost you'll report in section 12. So I mentioned before, this is kind of a good rule of thumb is to think about, well, what's your total expenses in a year, and what are you reporting across all the different sections, and they should roughly add up. That is definitely true for organizations that primarily provide just ground ambulance services. Things may look a little different for organizations that also do other things, like our hospital, or also our fire department, or also furnish air ambulance services, which are out of scope for GADCS. So the note at the bottom, I think, is important to think through. If you're a pure play ground ambulance organization, that's what you do, then the sum of what you're reporting in section 7 through 11 should add up to the total cost you're reporting in section 12. If not, if you have some way to allocate your expenses across ambulance and other services, then when you think through, well, what share of those total expenses are ambulance? The same relationship holds true, but you have to think a little more narrowly about just your ground ambulance component. There are some activities and expenses that are out of scope for GADCS. Air ambulance is one of those examples where if you happen to, sometimes this applies to providers where you might operate some air ambulance and some ground. There are other for-profit companies that might be in that scenario, even though it is probably pretty rare. But it's a great example of an activity, expenses and revenue that are just out of scope and should not be included in GADCS. There are a couple other examples where there are activities like fundraising that are just as a rule excluded. There are other examples like fire department operations where there are some places where you'll be asked to report on fire activities separately, for instance, in the labor section, and others where it'll be out of scope. Section 7 asks about staffing and labor costs. There's a webinar that CMS hosted just on section 7. I won't go into much detail here. The questions basically ask about what kind of staff you use. So this is an example where there's some questions up front that ask what staff categories apply to your organization. And then for each of those categories that you say, yeah, this applies to us, then you'll report across all of the staff in that category, total hours worked and total compensation. One of those other changes in the calendar year 2022 final rule is when you're reporting total hours, you'll report a total worked at your organization, but then also report it broken out in 3 parts: so ground ambulance, in fire, police, and other public safety, if that applies to your organization, is 1 number, and then everything else. And the sum of those 3 components should equal the total hours worked at your organization. There are also separate questions for volunteer staff in terms of the number of volunteers, the hours worked, and then also any expenses associated with volunteer stipends, honoraria, etc. Sections 8 and 9 ask about facility and vehicle costs. They share a similar structure where you'll report information on individual facilities and vehicles. You'll report some other information, expenses related to facilities and vehicles, insurance, maintenance, that kind of thing, overall, rather than broken up facility by facility or vehicle by vehicle, to try to cut down on the burden of reporting in these two sections. Won't go into much more detail here. Pretty straightforward questions that we think many organizations already track. Section 10 asks about equipment, consumables, and supply costs. There are a couple of categories here. There's a breakdown between capital and other expenses. Many organizations will capitalize expensive equipment and things like ventilators and power lifts and things like that. So there is a way to separate both medical and non-medical equipment out on that dimension. There are some separate questions for uniforms and for medications. Medications can be a very sizable expense for some organizations and much less so for others. So that's broken out and separately reported. This is another one where the questions are probably pretty straightforward and probably along the lines of what you already track for accounting purposes. Then we get into section 11, which is a bit of a catch-all. If you're going through the instrument and you have an expense on your books that you haven't reported up to section 11, my advice is to find a home for it in section 11 so that you can include it in your reporting. There are two main parts to section 11. The first one asks about broad contracted services. So if you as an organization pay out some potentially large amount to another company to handle billing, accounting, vehicle maintenance, dispatch, IT, in some cases, staffing ambulances. If that applies to you, your organization, you can report that broader amount for a service contract in section 11 rather than elsewhere in the instrument. There are a couple categories that will help you slot that contracted service appropriately. There's also a write-in category. So this is first question asks about these broader contracted services. And then the later part of section 11 is a laundry list of other kinds of costs that CMS HERD ground ambulance organizations can incur. They cover things like biohazard waste, tolls for toll roads, and on and on. This is also a write-in at the end. So again, the goal of section 11 is to give you a landing pad for any expenses you haven't reported up to this point. Section 12, many people's favorite section because it is just one question. And this just asks for your total costs across your entire organization. This is one of just two places I can think of in the entire instrument where the question asks across your whole organization, not just your ground ambulance operation. So if you're a provider-based organization and you're part of a hospital, this really asks for your hospital's total costs, total expenses broadly. If you are fire-based, fire department-based, this would be the entire amount for your combined fire and ambulance operation, not just ground ambulance. The questions in the earlier sections are all worded and have instructions so that ground ambulance component's able to be pulled out. But here's one of two questions where the ask is broadly across your entire operation. That moves us into the last section of the instrument, which is section 13. And this section pivots away from expenses and into revenue. There are a couple different components to section 13. The first one asks for revenue from payers, from Medicare fee-for-service, and other insurers and healthcare payers. There are many categories listed here. Many billing organizations will already break out revenue from different kinds of payers. I will point out that there are some questions about separating between Medicare and Medicaid, different flavors. So fee-for-service flavor versus managed care flavors. And for some organizations, that can require some back and forth with their billing organization. Medicare Advantage plans are sponsored by commercial insurers. Whether or not payments from services provided to Medicare Advantage beneficiaries ends up in a Medicare category, Medicare Advantage category, or a commercial category can vary billing company to billing company, or ground ambulance organization to ground ambulance organization. So that's something else to check in on now before your data collection period starts. It may require a little tweaking to how you categorize revenue sources for ground ambulance services. One common question, particularly through the pandemic, is how to report information on healthcare services that aren't ground ambulance specifically. So vaccine clinics, community paramedicine, other medical services more broadly. There's a set of instructions in Section 13. If you can, this bank of questions asking for a breakdown of revenue by payer should be specific to ground ambulance services, which are narrowly defined as transports, other payment in response to EMS calls for service. There are, if you do have payment tied to treatment place, transports to alternate destinations, that can be included here. If there are payments you receive from insurers for other kinds of services, like community paramedicine, broader types of vaccine clinics, say, that should be reported later in Section 13 separately if you can. There's also, as in Section 11 for costs, in Section 13, there's a laundry list table where there are many categories, say 20 maybe, revenue from different sources. This is, again, where you should list anything you haven't reported elsewhere here so that the total revenue you report matches up with the total on your books. And there's a question in Section 13 asking for your total revenue across your entire organization. This is the second place, 2 of 2, where you should answer this question with your entire operation in mind, not just your ground ambulance operation. So that's all 13 sections. I have 2 more slides just to highlight some CMS education activities, and then we'll have roughly 10 minutes for Q&A. I want to point to the FAQ up on the Ambulances Services Center website. The FAQ grows over time as organizations ask more questions, and there's some great ones that have come in over the past couple of years. That document is the current version up is some months old now, and a refresh is pending. There's a lot of great information here, and if you have an organization that may be a little quirky on one dimension or another, this is a great place to check to see if CMS has already provided a response to some questions. As unique as each ground ambulance organization are, by this point, the RAN Crew CMS, we've talked to a lot of them, and the odds of someone else coming up with a similar question at this point are on the high side. So I encourage you to check out that FAQ. There's also a quick reference guide that's a kind of checklist to make sure you're collecting all of the necessary information. I've put the 2 CMS ambulance email addresses if you have questions that aren't addressed by the FAQ or quick reference guide. And then the one other resource I'd point you to are this slate of webinars that CMS has hosted. I think there are now 7, and they really cover a broad swath of GADCS, including an overview of the instrument. There's one just on Section 7 on labor, and then there are some targeted to specific categories of ground ambulance organizations. So organizations that use volunteer labor, fire department-based, other police and other public safety-based organizations, providers, so hospitals, primarily organizations billing Medicare under multiple NPIs. And there's also one on reporting revenue. So a lot of information there to sort through. The slides are available for those sessions. Recordings and transcripts are available for some. The most recent one, I think, was just last week. So probably still pending for the most recent ones, but a lot of great information there too. And with that, I will pause and take a quick peek at the Q&A to see if anything's come in. There are about 4 or 5 questions there. I'll just answer them live now. If you do have other questions, feel free to drop them in the Q&A box now. One person asked, to be clear, if we initially selected in round 1, is the fiscal year that we report now, 2022, due in 2023, instead of whatever dates CMS communicated previously, which I think was data collection starting in 2022. And that's exactly right. CMS, in their emergency waivers in response to the COVID-19 public health emergency, pushed all of the dates out. So the year 1 folks were sampled in 2019 and originally supposed to start collecting in 2020. That was then pushed out to 2021, which was now pushed out to 2022. So all the year 1 and all the year 2 folks will start collecting information at some point in 2022, and then you'll report at some point starting in 2023. We can't give you specific dates because, as I mentioned before, you've got a choice of when your data collection period starts, but that's right. Is the HCPCS revenue being reported gross or net of contractual adjustments? So this is the actual revenue coming in. There are charges are very different than the actual amount you bring in. There's also uncompensated care in the works here, amounts that you may never receive. So this is the actual realized revenue coming in over the data collection period, which CMS understands will be less than the billed amount at the point where you're reporting. Alan asked about self-pay. I went over this very quickly in the revenue section. There are a couple options on how to report amounts coming from patients. So CMS heard that some organizations categorize all amounts from patients as basically coming from patients. And that includes the cost sharing that say on Medicare fee-for-service, Part D, patients are on the hook for 20%. Sometimes that's paid by supplemental insurance, but sometimes that is paid out of pocket. So there are a set of questions that ask for Medicare, say, is that 20% that the patient's on the hook for included in your Medicare revenue line or in your patient self-pay line? You can report it either way, but the instrument does have a question for you for every payer to check off. Is cost sharing in the amount you're reporting for that payer or not? And then separately, there's a self-pay category. So self-pay could be, depending on how you answer those screening questions, it could be just patients that basically don't have insurance or where transport wasn't covered and they paid entirely out of pocket. Or it can be a combination of that plus cost sharing. If your accounting practices is to put that cost sharing amount in that self-pay category, that's okay. You don't need to change the way you're handling that. Deborah asked a question: for a county-based ground ambulance service, do we report the entire county expense and revenue on the 2 general questions? This is an area where my sense is there will be some future clarification through an FAQ. The answer there is no, you wouldn't. It would be limited to your ground ambulance service. The exact guidance on how to do that, I keep an eye out on the FAQ. But that's a great question, Deborah, and one we've gotten from many folks along the way. Someone else asks, if your billing agency doesn't post by line item for revenue on HCPCS, there is a requirement to break it out by HCPCS. So many organizations using a billing service will, for billing Medicare, say you've got to convert that at some point into HCPCS that map up with the ambulance fee schedule. Other payers may use a slightly different set of codes or may make some other allowances to cover some other services. It's another area where I expect a future clarification in FAQ how to handle some of those state-specific Medicaid program codes that commercial insurers may use that aren't on the AFS. Just a kind of general rule of thumb would be to map up those services to the HCPCS listed in the instrument as best you can, but those do need to be broken out by HCPCS. One question comes in: if your accounting's accrual based, you still report revenue on a cash basis. If we do this, our revenue reported will not match our financial reports. That's correct. CMS understands that there will be a mismatch between the amount that you'd have on your books from services rendered during the data collection period versus what you actually brought in. And given the need to standardize this across all organizations, some of which do operate on a cash basis, the instructions are what they are, to report revenue that actually was realized during the year. Someone asks, how do you stipulate insurance payments sent to the patient? I think I got that one at a question or two ago. There are a couple different ways you can report those amounts that get passed on to patients in terms of cost sharing, whether it's the Medicare Part B 20% or something else. In a deductible, it might be the entire amount gets passed on to the patient. So depending on whether or not in your practice now, you would count that as revenue under the insurer category or under a self-pay category, you can go either way there. And then the last two questions, this would be a miracle if nothing else comes in, but keep on asking if you have more. The last two questions have to do with timing and whether or not CMS has mailed out letters yet. The year one folks did receive a letter or email way back in 2019. The year two folks are selected, the list of NPIs. I noticed that the AAA folks helpfully dropped the link in at the start of the chat here to the lists. The year two list is posted, but notification letters have not gone out for year two folks. As I mentioned at the beginning, CMS will send out another round of notification letters to all year one and year two organizations, regardless of whether you did or didn't get something in 2018. CMS will begin sending out letters again this month. So all organizations that are that will have to start collecting data in 2022 will be notified or have another official notification letter come in soon, starting this month. And then the last question asks, when those notifications come in, where will they go? CMS is using the primary contact address listed in PACOS. So if you have an address listed there that maybe is not the one where you'd ideally like a notification letter to go in terms of primary practice location, you might want to get in touch with the folks that will be receiving it and just alert them that it's coming. There are also some organizations in PACOS that have an email address. Some Medicare administrative contractors or MACs will also be sending notification letters to email addresses. So it may be that some organizations will receive a notification letter via both email and hard copy mail. Whew. With a minute to spare, that's all the questions. I will thank everyone for your attention today and for being here. It was a pleasure to talk through GADCS. I encourage you to take a look at those CMS materials and email in if anything else is still on your mind after the presentation today.
Thank you again, Andrew, and thanks to all of you who joined us today. As a reminder, the link for the slide deck, as well as a recording of today's presentation, will be emailed out in tomorrow's Daily Digest. We thank you for your time and attention and look forward to seeing you on a future AAA webinar.